I'd like to welcome everybody. And Gecko is hosted by the Gastro Foundation and associated with Project Echo, University of New Mexico. And these sessions are held weekly on a Wednesday. So the chat will be open for questions. So please feel free to ask as many questions as possible during the actual talk. So it gives me great pleasure to introduce our speaker, a good friend of mine and the past president of the HPBASA, Dr. Sean Burmeister, who's got a huge pancreatic interest and real expertise in endoscopic ultrasound. And he'll be talking to us about pancreatic cysts. So Sean, over to you.
Okay, thank you, John. Thanks for the very kind words and the invitation to interact with junior colleagues and senior colleagues I see amongst the participants. Right, so I'm going to just share my screen. Right, John's, if you can just sorry, just getting my slides started.
We can see your slides.
All right, John, you can see that okay?
Yeah, all good.
All right, excellent. Okay, and again, thanks for the invitation. So I'm going to kick off by illustrating a case. I think, there's quite a lot of, I wanted to specifically leave some time for questions at the end, because I think potentially this can be a confusing topic, and I'd like to leave time for discussion. So I'm going to show you one case, and then just to illustrate some important points. And then I'm going to just walk you through sort of an approach to cystic neoplasms overall, together with some of the more what's kind of recent in terms of guidelines. And then a couple of sort of key points, I think, the worthwhile take-home messages, and then leave some time for discussion at the end. So this is a patient that I saw earlier this year. And I want to kick off by giving the sort of the history and some of the story here, and then illustrate some of what I think are the important points to take away from this case. And I think there are quite a few. So this is a 65-year-old man. He's a mechanic, and he's used to working long, hard days. And consequently, he, when he returns home, he likes having a few whiskeys in the evening. And his history is that he generally has 3 to 5 whiskeys a night after work. But this has been for some years. He's 65 now. He's nearing retirement. And this is about a 30 to 40 year history of that. In addition, he smokes a pack of cigarettes a day. But what is notable in the history is that although he drinks not small amounts, it's very regular. He never binges, and he's never had an attack of pancreatitis before. And he doesn't drink anything other than his 3 to 4 whiskeys a night. He presented about 16 months ago with a first attack of pancreatitis. And this was diagnosed fairly readily on presentation to the emergency room. And he was referred to a general surgeon who actually managed him conservatively, and he settled down symptomatically within about 24 to 48 hours, returned home, only to return a day later complaining of ongoing pain and some nausea and vomiting. So I've given Malini a head up that I was going to put her on the spot, so to speak, this afternoon. So Malini, are you with us? Can you hear us?
Hi, yes, I'm here.
Okay, great. Now, and just for everyone else, Malini is blind to this case, so we're going to walk through it as we would any other case. What do you think of this CT scan, Malini?
Okay, so it's an axial view CT scan of the abdomen, a single slice at the level of the kidneys and the renal vessels. I can see a bit of calcifications in the aorta. The only thing remarkable is a bit of fatty stranding, some sort of inflammatory process around the bowel and involving the vessels of the mesentery at that point. Yeah, I think you can see the tip of the liver, but not much else.
Okay. So yeah, I mean, I think that's so there's some evidence of chronic vascular disease, some clear inflammation around the head of the pancreas. The vessels, as you say, are clear, and nothing else really to be of great concern on this single slide. So I'll tell you that he gets admitted. There were some problems with gastric, sort of delayed gastric emptying and a sort of physiological gastric outlet obstruction. He had nausea and vomiting for 2 to 3 weeks, remained in hospital, but subsequently ended up being discharged. I think I mentioned at the beginning that he's 65, and he has no prior presentations. There's no remarkable family history either. I've given you the history of his alcohol intake. So, Melanie, what do you think should happen at this juncture? So you've got this imaging. I've given you sort of all the relevant points in the history. What do you think should be done for this patient moving forwards? He's now settled completely and discharged home.
Okay, so I think a few things just in terms of history. You mentioned that there was no clear binge, so the etiology is still a bit uncertain, even though he does have a chronic history of drinking. So I'd want to ask about any loss of weight, any new onset diabetes that he might have.
So he's a long-standing diabetic of 30 to 40 years. He went through a brief period some years before we tried alternative remedies to control his sugar. And that actually worked for a while. But about 6 to 8 months ago, or prior to this presentation, his sugar control suddenly worsened, and it in fact required him to then go on to insulin.
Yeah, so that can be a worrying symptom. New onset or worsening of existing diabetes, just in terms of underlying malignancy. And then the other thing would be exocrine dysfunction. Does he have steatorrhea, any signs of exocrine insufficiency?
Okay, there's no evidence of his weight has remained stable. There's no change in his stools. There isn't a fecal. He didn't have a fecal elastase, but yeah. So that's
okay. And I assume he also was not jaundiced at the
no,
time of this presentation or any previous
yeah.
episodes. Okay. Yeah. So if it's completely settled, then I think I would want to look for any other causes like gallstones to exclude that as a cause of pancreatitis, and then a CA19-9 because of this worsening of the diabetes.
Okay.
Which would probably be my next two steps.
All right. So until the CA19-9 is normal, the ultrasound doesn't demonstrate gallstones.
Okay, then I think I would follow him up. His symptoms have completely resolved, but I would probably want new imaging then, say a month or two after this initial episode, once that inflammatory process has resolved. Yeah, so I think I'd repeat a CT scan then at that stage.
Are there any other investigations that you would entertain at this juncture? So I mean, you've excluded gallstones. You think that you question the alcohol contribution, shall we say? Are there any other things one should think about?
The other investigations one could do would be a fecal elastase if you're still worried about exocrine insufficiency.
We're thinking
and just
etiology.
Other causes of pancreatitis, so an IgG4 would be important. Possibly an MRCP to look at that duct. Yeah, I think those would be the common ones.
So I mean, I think one should just break it down into sort of the basics. I mean, the other things are biochemical things. You definitely want to look at calcium and triglycerides. I think a careful drug history would be important. I did mention that there's nothing in the family history, but again, that would be important. And so, but let's say all of that workup comes back negative. So you have mentioned further imaging, and I think it would not be unreasonable to bring him back. But what is the optimal imaging for an underlying possible non-benign pathology? Once you've excluded all of the typical things by way of, in other words, gallstones by ultrasound, looked at his drug history, looked at metabolic factors, what would be the standard in terms of examination for an underlying non-benign cause?
Then I think an EUS, an endoscopic ultrasound, would be probably the best imaging if you're worried about an underlying malignancy.
All right. So generally, yes, EUS is probably the best for looking at the pancreas, and we would usually combine it with an MRI and an MRCP, looking specifically at ductal abnormalities and other parenchymal things. Okay. However, that is not done for this gentleman. He's discharged on his way. It's presumed that this was alcohol related, rightly or wrongly, and he's not followed up any further. But he returns 4 months later with a second attack of pancreatitis. You want to have a look at this scan and tell us what you think now. So this is now 4 months later.
Okay, so once again, single slice axial view of the CT abdomen at the level of the kidneys and renal vessels. So now I can see what appears to be a cystic lesion around the head of the pancreas. I can't see any, I'm not sure if this is a distal duct that I'm seeing in the body, but there's no clear communication with the distal duct. This cystic lesion also looks like it's rim enhanced. There's an area of thickening on the posterior aspect of the wall, but otherwise it looks fairly homogeneous. Yeah.
So agreed with Nacho. So where do you think this is arising from? Where's the cystic structure arising from?
So this could be arising just from the body of the pancreas or from the duct. I can't see any clear ductal communication, so I wouldn't commit to saying that it's from the duct, but it looks like it's arising from the pancreas.
Is it the exact sort of anatomy of where we are at the moment? So that is the portal vein, or superior mesenteric vein, rather.
SMV, yeah.
This is SMA over here. So this is actually sort of inferior head. That would be uncinate process over there. So this is essentially arising from the head of the pancreas. And you're not seeing the duodenum on this cut, but the cyst would be related to the duodenum as well. All right. So this is head over here. Again, there's some inflammatory standing. As I mentioned, this is a repeat presentation with pain. And again, pancreatitis was diagnosed again biochemically. But obviously this imaging, as you've mentioned, there's the cystic lesion. It's arising from the head of the pancreas over here. The uncinate would be over there. There's some inflammatory stranding again. This is the SMV, this is the SMA. And as you mentioned, there's some thickening of the cyst wall over here. All right, so he's admitted by a general surgeon. And the general surgeon says, look, you've got a cyst that's developed from your pancreatitis. We don't think we should do anything about it right now, but please go on your way, but please stop drinking because this is clearly causing you to have recurrent attacks of pancreatitis. And the patient is sent on his way. What do you think of that approach?
I mean, I don't think it's unreasonable diagnosis. He has had a recent attack of pancreatitis. The likeliest diagnosis is a pancreatic pseudocyst. But what is a little bit concerning is just that thickening in the posterior aspect of the cyst that doesn't look completely in keeping with the pseudocyst and with that history that we talked about. Yeah, so I think it should have had a bit of further evaluation, but it's not an unreasonable diagnosis to consider pseudocyst.
So I would agree with you that it definitely figures in the differential. However,
but it's also a strange place, sorry, for the pseudocyst to occur. It's not usually in the head of the pancreas. That is an uncommon area as well.
Well, certainly not like this, and certainly not where you've kind of got this rim of tissue in the wall of it, as you've said. But
Yeah.
I think just as a general principle for our audience to take away, I think that first, so definitely an inflammatory cyst, let's call it that, because it could be a pseudocyst. I mean, the CT is not good at picking up necrosis. It could also be walled off necrosis from the previous attack. I mean, but let's call it an inflammatory collection as a consequence of pancreatitis. That definitely figures in the differential. However, in an elderly patient, I mentioned he's 65, with a second attack of pancreatitis, without a clear alternative or without a clear etiology having been diagnosed, one has to have suspicion that there is an underlying process going on here. And it absolutely warrants further evaluation at this stage by an HPB unit. Okay, so, but as I said, the patient is seen by a general surgeon. He's told that he's now got a pseudocyst as a consequence of his pancreatitis. And again, he's sent on his way, again, with no plan for follow-up. A year later, the patient develops pruritus and presents to an emergency room after about 2 to 3 weeks. His initial liver functions, although his bili is only 19/12, a total of 19, a conjugate of 12, his alk phos and gamma GT are about 4 to 5 times normal. And an alert clinician requests a repeat CT scan and refers him on to an HPB unit. You can't quite appreciate it, but the gallbladder is a little bit more prominent here, and I'll tell you that there was some evidence of biliary dilatation. Perhaps a hint of pancreatic duct dilatation in the body and the tail. But in terms of this image here, Melanie, again, what do you see here?
Yeah, okay. So I see that cyst looks a little bit more organized now, less inflammation around it. Definitely thickened areas of that wall and that posterior and medial aspects of it. It looks like there's almost an additional small cystic area next to it. I'm not sure if that's duct or if that's the pancreatic duct that's over there. Yeah, that.
Yeah.
But possibly the pancreatic duct over there. And then, as you mentioned, a bit of a distended gallbladder.
Yeah. Okay. So as I've said, the issue here now is, or the symptom is pruritus. But what are your thoughts at this junction, and how would you proceed from here?
So I'd be very concerned about the pruritus and the biliary dilatation. Is he jaundiced?
No, his total bili was 19 and conjugated was 12. As I said, the alk phos and gamma GT were about 4 to 5 times normal. And he's not frankly jaundiced. You'd need a bili of about 50 for that. But he certainly is pruritic.
Okay. Yes, I'd be concerned about an underlying malignancy for him. I would repeat the CA19-9 and see what that is. Did he have one?
He did. It was 98.
Okay, so it is raised. And then I think the next step would be an EUS.
So I would agree with you on that. And I will tell you that this is an image focusing. So what we did is we identified the pancreatic duct and we followed that down into the head. This is the pancreatic duct here. It measured in the region of 6 to 7 millimeters, which obviously is raised. And then there's an abrupt sort of termination or occlusion of the duct as one moves into the head with an inhomogeneous area to meters. We then looked specifically at the cyst, which you see here, and you can appreciate that there's this thickening, this mural thickening on the wall of the cyst, which is what we've already identified on the CT scan, and certainly that would be something of concern. I think what's important to appreciate here is that this is sitting on this side of the cyst as opposed to that. So it's clearly not gravity dependent, so it's not debris within the collection. Certainly it could, in a patient who's had pancreatitis, conceivably it could be necrotic material. But this far down the line, you really would have expected that to liquefy. And so that remains as very suspicious tissue. So we biopsied this, and I think just not sure how many of you will have had the opportunity thus far to train in EUS, but just to point out that in the setting of a strictured and dilated duct, you really want to try and aim your needle without entering the duct, but passing through the tissue that is responsible or near the where the duct strictures down. So that would be this area. And you can appreciate that this is about this distance is about 5 to 10 millimeters. So ideally, perhaps the angle should be there to really get the area of interest, but this is probably adequate. Certainly with the bulk of the lesion being over here, I think we're well within the lesion, and we're certainly close enough to where the duct strictures down. And then we also, yeah, so I haven't got a picture there, but we also biopsied this area separately. And I'll tell you that both biopsies came back as showing malignant tissue. And this patient subsequently went on to, he was upfront resectable. You'll appreciate from his CT scan that the SMV and SMA were well clear. So this was deemed an upfront resectable tumor. And in discussion with the oncologist, he did have some baseline renal dysfunction, and they did not want to run the risk of him developing renal problems on chemo without having had his surgery. So that was typically our preference is for upfront neoadjuvant therapy, but in this case, we decided to reserve the chemotherapy as an adjuvant tool and proceed with upfront resection, which he had. And he had a T3N1 pancreatic cancer resected, and he is now on adjuvant chemotherapy. Okay, so I think it just illustrates just a number of points. I think it can be quite challenging, patients who present with pancreatitis who have an underlying malignancy, but it's definitely something that you need to keep in mind, especially in the older population, patients older than 55. There's a definite association between acute so-called idiopathic pancreatitis and an underlying or occult malignancy, and it really behoves one to exclude that. And then again, and then I think the other important point in this case is clearly when you have a cystic lesion with clear mural abnormality that really should arouse suspicion, and one has to I think it behoves one to exclude malignancy in that setting. Okay, so let's focus down on sort of malignant cystic tumors and their precursors. So, although that's not the case, not really how this case is presented, but certainly the use of cross-sectional imaging, especially in preventive screening of healthy individuals, has presented us with the problem of the increased detection of incidental cystic neoplasms. MRI probably has the greatest sensitivity for picking up these lesions, and it detects it in up to 50% of people, and that correlates with autopsy studies. Obviously, the concern is that some of these cystic tumors have a potential for malignant change, and intervening timeously is paramount as opposed to avoiding unnecessary surgery in what are actually benign lesions. So it's really important that we differentiate between what are the worrying lesions and what are the not worrying lesions. Certainly, age correlates with the presence of cystic neoplasms. And an important factor, and again, this was demonstrated in our patient, diabetes has been suggested to have a causative link with IPMN tumors, especially when there's insulin use. And a significant amount of patients, we know that patients with pancreatic cancer, there is an association with the development of diabetes in the 6 months prior to diagnosis. And we certainly see this in the cystic tumors as well. Chronic pancreatitis has an increased risk of IPMN, although the mechanism for that is not entirely clear. And in turn, patients with IPMN are not only at risk for undergoing what we call malignant change, they are also at risk for developing de novo ductal adenocarcinomas. And this may have been something at play in this patient. Okay, sorry, I'm just struggling to advance. Okay. All right, so let's just look, what are the things that we're dealing with here? So as we mentioned in our patient, I think when you see the vast majority of cystic lesions of the pancreas are going to be inflammatory cysts, probably up to about 75 to 80% of patients. But that's, of course, is all comers. 20% of patients are likely to present with a cystic tumor. Now, or 20% of cystic lesions are going to be cystic tumors. All right. Now, the next step, when we talk about cystic tumors or cystic neoplasms specifically, it's worth dividing them up into relevant or categories that help us to approach the condition. So I think the first thing is to consider what we call mucinous lesions, or MCNs, as well as intraductal papillary mucinous tumors, or IPMN tumors. So MCNs and IPMNs fall under the category of tumors that have mucinous epithelium. There are differences between the two, in particular the presence of a variant stroma on histology in MCNs, but we can talk a little bit more about that later. But we can certainly group MCNs and IPMNs, and these are probably the two most relevant ones to us under tumors that have mucinous epithelium. All right. Then you may also have serous tumors, and these are called serous cystadenomas, and these are almost universally benign. We're going to talk about clinical characteristics in a moment, but they're certainly worth remembering from the perspective that you don't need to do anything about these tumors when you diagnose them. If you have a very, unkind examiner, they may ask you about von Hippel-Lindau disease and what cystic tumors those patients get. So von Hippel-Lindau patients typically get serous cystadenomas, but they're also at risk for neuroendocrine tumors. So those are the two things to remember in patients with von Hippel-Lindau disease. All right. Now, switching over to what is left in sort of the rest of what we may be faced with in terms of cystic neoplasms. There's also the next sort of common thing to think about would be SPEN tumors, or what are called solid pseudopapillary tumors. And then occasionally you can also get degeneration of more solid tumors, in particular neuroendocrine tumors and very occasionally ductal adenocarcinomas. These tumors may undergo degeneration, resulting in sort of necrosis, liquefaction, and what usually appears as a combination solid cystic tumor or a cystic tumor with a solid component. And there you need to think about these two to a greater or lesser degree. And then lastly, there's acinar cell carcinoma, which is a very rare tumor, and I'm not going to spend too much time talking about that today. Okay, so what I want to talk now about is an approach, a clinical approach to each of these lesions. And I think, making the correct diagnosis in these tumors is often about taking a holistic view and looking at both the clinical picture, the radiological picture, and certain specific biochemical tests. And sometimes it's a slam dunk, and sometimes one or more of the tests may be equivocal, in which case you need to really be able to look at all of the information. But the key thing here when it comes to these cystic tumors is appreciating that they have a malignant potential, although it is variable between what you're talking about. So the serous cystadenomas are fine, and we wouldn't do anything more about them. The SPEN tumors and the cystic neuroendocrine tumors, they have a malignant rate of about 10 to 15%. So a little bit lower. We don't perhaps need to be overly concerned about them in terms of how quickly we need to address them, but quite often SPEN tumors present with mass effects. Neuroendocrine tumors are often picked up incidentally in this setting, but their malignant rate is low but not negligible. When we move on to the mucinous lesions, however, we can appreciate that the MCN tumors have a not unappreciable malignant rate of up to 40%. So we take these quite seriously. And then the IPMN tumors, and it's variable between the type of IPMN tumors. Now we differentiate between small branch and main duct, and then a mixed type. And these have variable malignant potential from about 10 to 30% in side branch type, and up to sort of 80 to 100% in the main duct type if you wait long enough. But probably it's reasonable to talk about a mean rate of around 60 60% or 2/3 of patients will have malignant potential or develop malignancy within a reasonable period from diagnosis. Okay, let's look at each of these in turn. So I'm going to start with the less common pathologies and work our way towards the more common, and as well as the ones that cause sort of greater problems for us. So let's start with the SPEN tumors. Now, just a little sort of anecdotal aside. Some of you may know Professor Jake Kricher. He's a well-known HPV surgeon, one of the sort of doyens in our discipline in previous years, and a mentor to many of us. And Prof. Kricher always used to talk about the daughters, the mothers, and the grandmothers. And this will become evident as we move through the rest of the talk. But essentially, the SPEN tumors are the daughters. These tumors occur in usually in young women, almost always somewhere between their teens, 90% female. Often these tumors are mostly solid with cystic components, and they're not often incidental, though they can be. Most of the time, these patients present with fairly large lesions that are causing mass effects and discomfort. Usually they are solitary. Okay, so that is the SPEN tumors. The cystic or the neuroendocrine tumors with cystic degeneration, these occur in older patients in the 5th to 6th decade. There's an equal sex distribution. And similar to the SPENs, they have solid and cystic components, although usually you'll see a solid part with an accompanying cystic component. They're usually solitary. They have a relatively low malignant potential. I've struggled to find literature that really gives an indication of how we can determine what their malignant potential is. And essentially, most of the literature suggests that the greater the solid component, the greater the potential for malignancy. What I want to point out to you here is, so this is images, EUS, CT scan, and MRI. And if we start with the CT scan, you can appreciate that there is a lesion there, but it's a little bit difficult to appreciate. The MRI certainly gives us a better appreciation of the lesion. It's more well-defined and visible on the MRI. But this particular image might be slightly falsely reassuring, suggesting that this is largely a cystic lesion and something that we would not necessarily need to be too concerned about. On the other hand, when we look with endoscopic ultrasound, here we can see the vein and the tumor nestled against it. And here we can appreciate that, in fact, there is a reasonable solid component to this lesion. And certainly one would want to biopsy that. And perhaps you're going to have a slightly lower threshold for intervening invasively. So just a point that EUS really is useful in these scenarios. Okay, so we're going to just sort of digress for a brief moment. So SPEN tumors and cystic neuroendocrine tumors, important to remember, but they are in the minority and they have a lower malignant potential. The serocystic neoplasms, these are fairly common, in fact, and these occur in the grandmothers. The patients here are almost always in the 5th to 7th decade. They are usually female. It's probably a little bit more than 70% to be fair. And these are often sort of septated or have what is called a microcystic, although it can be macrocystic, but there's sort of a honeycomb appearance. And that's typical. And you can appreciate that here. Even on the CT scan, you can appreciate the septations there, and they're very evident on the endoscopic ultrasound here as well. These lesions, although they can be multiple, they are typically solitary. But the key thing here really to say is that these can be confused with side branch IPMN, which often is described as a bunch of grapes. And unfortunately, biopsying serous cyst adenomas, it's actually quite difficult to get tissue that confirms the diagnosis for you. And so in this setting, with these tumors, it's really important to try and get some fluid and sometimes repeat that investigation in terms of trying to get histology or cytology. But certainly the fluid biochemistry can help one discriminate between serous cyst adenomas and side branch IPMNs. Okay, moving on now, we're going to focus down on the two lesions that concern us the most, certainly in terms of malignant potential. The MCN, so this is now the mothers. Okay, so the SPENs were the daughters, the serous cyst adenomas were the grandmothers, these are the mothers. So MCNs typically occur in patients in their 5th to 7th decade. They're almost always female. The tumors often occur in the tail, and they usually are unilocular or macrocystic. We often talk about a claw sign, and that usually means that you can see some thickened pancreatic tissue that extends around the rim of the cyst. But certainly they can be confused with tail of pancreas pseudocyst, especially where perhaps there's been acute or chronic pancreatitis, and there's been what's called a blowout in the tail of the pancreas. But again, if you've got a thickened rim of tissue, again, that claw sign that we talk about, that would raise concern for you in terms of the appearance on the CT scan. Obviously, EUS here may be particularly valuable. You might want to do a diagnostic aspiration here. And in that case, what you would do is you would aspirate the cyst to dryness. You would FNA the wall of the cyst, and the fluid biochemistry, which we'll accumulated, you would decide on the optimal mode of drainage. Alternatively, if you had a result that indicated an MCN, you would look to resect this. All right. Lastly, the IPMN tumors. As I mentioned, there are essentially 3 types: side branch, main duct, and mixed type. The main duct essentially is described when the main pancreatic duct measures greater than 5 millimeters in diameter, and side branch when you have a cystic lesion, which is shown to be an IPMN arising from the side branches, and in turn, again, also measures more than 5 millimeters. For both types, the age is typically 5th to 7th decade, although it can be variable. The sex distribution is equal. As we mentioned, in the main duct type, you have a dilated main duct, more than 5 millimeters. In the side branch, you have dilated side branches with a cyst more than 5 millimeters. And then when you have both, that's when you have the mixed type. The key thing here, and one of the differentiations between IPMN and MCN is the connection with the ductal system. So clearly in IPMN, there is communication with the ductal system, and when you aspirate fluid from these lesions, you will get a high lipase or amylase. MCNs typically do not communicate with the main duct, and therefore will have in comparison, a low amylase or lipase level, although this is not always true. There are exceptions to the rule where the cyst may communicate, and this applies also to the serous cyst adenomas for that matter. I think an important concept when it comes to the IPMN tumors is that this should be considered a field defect problem. In other words, the entire ductal epithelium is at risk for undergoing change. So hence, these lesions can be solitary or multifocal. When they're solitary and are resected, these patients need to be submitted to surveillance, remembering that I mentioned earlier also that not only are they at risk for malignant change, with an IPMN lesion becoming or undergoing malignant transformation, but these patients are also at risk for de novo ductal adenocarcinoma development. So these patients need careful follow-up and surveillance. Okay. What I'm going to move on to now, so John, I'm not sure if you feel we should take any questions at this stage or just continue on in terms of sort of management. I think probably it's better to continue and take questions at the end.
I would agree with that, Sean. Please go ahead.
Okay, cool. All right, so there are lots of guidelines that have been published in recent times and from a number of different places. Probably the three key ones to consider are there are American guidelines, there are European guidelines, and then there are what is called the IAP guidelines or the International Association of Pancreatology guidelines, which comprise sort of authors from all over the world who are members of the International Association of Pancreatology. These are sometimes referred to as the Japanese guidelines because the first time that they were drafted was in Fukuoka by an author called Tanaka. He's now, I think, probably retired. He's quite old now, and his place has been taken by Otsuka. But suffice to say that IPMN tumors are very prevalent in the East. And so the Japanese have been prolific in writing about them and producing evidence-based guidelines in terms of managing. And these IAP guidelines are essentially a descendant from that. So you may hear about people talking about the Japanese or the Fukuoka guidelines. These, to be more correct, we would talk about them as the IAP guidelines, and most recently they were put together in Kyoto. These are probably the strictest guidelines and probably the guidelines that people follow most. But having said that, we should be cognizant of the emergence of the European guidelines. And there are efforts now, and we'll talk about it a bit later, there are efforts to bring these two, or bring all of these together for that matter. The American guidelines, I wouldn't generally suggest to people in South Africa or in our region to use. People don't refer to this much, and to a large degree, these guidelines have been quite lax and don't correlate that well with what is in the IAP and European guidelines. So I'm going to focus on these two. Now, the more recent edition, which is from last year of the IAP guidelines, is quite busy and a little bit difficult to follow. And so I'm going to try and sort of just clarify it for you. So essentially what the IAP guidelines do is divide lesions up. And to be fair, they are referring mostly to IPMN tumors, but also to some degree MCN lesions as well. But the key issue here is that they differentiate between high-risk stigmata and worrisome features. And this does correlate with the European guidelines to a significant degree. But the point being that high-risk stigmata, so these patients, if you look at all of the patients that have one or more of these criteria, in a significant proportion, there will be an existing cancer. So patients who present with jaundice, patients who have a mural nodule that is more than 5 millimeters, or a solid component. And I'll tell you that our patient that we presented early in the meeting or the presentation clearly met this criteria, and so that patient should have been assessed as soon as there was that cystic development and the noting of the thickening of the wall. A main pancreatic duct of more than 10 millimeters, and then if the patient has had an EUS or any kind of tissue acquisition which is suspicious. So these patients almost always will have a cancer, and these patients should almost always proceed to surgery if this is appropriate in terms of patient's fitness and comorbidities, and looking and take into consideration all of these factors. Okay. The next group would be what we call worrisome features. And here there's a list, okay? And you'll notice at the top of the list, again, episodes of acute pancreatitis. In fact, even a single episode of acute pancreatitis in a susceptible patient. Increased levels of CA19-9, new onset or acute exacerbation of diabetes within the previous year, This is something we've already spoken about. A cyst greater than 3 centimeters or 30 millimeters. Now, I'm going to come back to this in a little while. This is something that has come up for a fair amount of debate and moderation in recent times. So we'll come back to talk about that. An enhancing mural nodule, but that is less than 5 millimeters. Thickened or enhancing cyst walls. A main duct between 5 and 10 millimeters. Abrupt changes in the caliber of the pancreatic duct. Lymphadenopathy and growth of the cyst at greater than 2.5 millimeters a year. So all of these features would be considered worrisome and require further consideration. If they are present, you need to look a little bit more carefully at your patient. And certainly, if the patient is having repeat attacks of acute pancreatitis, that becomes major concern and would direct you towards surgery. Similarly, if there was more than one feature of the worrisome features that would augment the likelihood of malignant change, again, that should divert you towards surgery. And then if you are young and fit, and this last is sort of comment is a newer addition to these guidelines, and it really recognizes what the European guidelines were emphasizing. And we're going to talk about that in a moment. But the bottom line is if you have one of these criteria and you're young and fit, one should be asking the question whether it isn't better to just resect a lesion if it can be done in a relatively low risk way to avoid a long duration of life with progressive risk for malignant change and prolonged observation or surveillance. All right. If you are less concerned, then you may move down the route, and in particular, if the only feature is that of an enlarged cyst. So I apologize, I didn't have a chance to add this case to the presentation this evening, but I've recently seen a patient who was seen a number of years ago with a 4.5 centimeter cyst in the body of pancreas and 3 smaller cysts of between 1 to 2 centimeters. And this patient was told they had simple cysts of the pancreas. That's not an entity, by the way, but that's what they were told, and they were sent on their way. And the patient returned 4 years later with a body of pancreas cancer that is developed in the 4.5 centimeter cyst. So that's a patient that only had cysts as their risk factor. And so what I'm saying is that if you have a single cyst or a cyst in the presence of other cysts, where that is the only criteria, then size does play a role to some degree. And let's talk a little bit more about that. So if you have an isolated cyst that is more than 3 centimeters, then if you're not going to do anything, then you need to be watching that patient quite carefully. And how you proceed depends on the size. If it's less than 2 centimeters, you're less concerned. You'll image in 6 months, and then if it's stable, every 18 months after that. If it's between 2 and 3 centimeters, here you're going to be a little bit more concerned, but having imaged once at 6 months, probably yearly is adequate. But once you get more than 3 centimeters, you want to be following these patients quite closely, and that involves imaging at least every 6 months. So 3 centimeters is still a cutoff, but in the previous guidelines, more than 3 centimeters, the Japanese would be keen to resect you. Now they're accepting that it's probably still reasonable to observe you, but it needs to be frequent surveillance. And if in either of these categories there's any progression, well, then you need to be thinking about going to surgery. If there's no progression, then you may continue close surveillance. In the smaller lesions, obviously if there's progression, more concerned, thinking about surgery. If not, if you've had stable surveillance for 5 years, you can question whether you can stop surveilling these patients. All right, so it's a little bit difficult to remember, but I think it's fair to say that if something is more than 3 centimeters, you're going to watch it carefully. If there's any evidence of progression, you're going to refer for evaluation for resection. Between 2 and 3 centimeters, also watching closely, but slightly less so. Again, any progression, surgery. The smaller lesions, these almost always stay behave in an indolent fashion. And once you've watched them for a while, you can stop watching them. Okay. I want to just, I think if you're going to learn or focus on one set of guidelines, I would suggest the IAP guidelines. However, it is worth mentioning the European guidelines. The key difference here is they focus quite significantly on what the patient's comorbidities are. So they differentiate between absolute indications. So if you have any one of these, you should be going to surgery. So positive cytology, solid mass, jaundice, mural nodule more than 5 millimeters, main duct more than 10 millimeters. So again, very similar to what we saw in the IAP guidelines. You have any one of these, then you should be going to surgery. Then you have relative indications, and these correlate very much with the worrisome features that we saw in the IAP guidelines. So growth more than 5 millimeters. The IAP, it was 2.5. Elevated serum CA19-9, main duct 5 to 10. They are more worried by cysts that are more than 4 centimeters. Again, the new onset diabetes, the acute pancreatitis, and the mural nodules. If you have a relative indication, if you only have one, but you are fit without significant comorbidities, then you would go to surgery. Okay. However, if you are a patient with significant comorbidities, then you need 2 relative indications in order to go to surgery. If you have comorbidities and you only have one relative indication, you undergo intensive surveillance with clinical evaluation, serum CA19-9, and MRI or EUS, or alternating between the two. All right, so not the world of difference between the two. I'm not going to spend a lot of time on these slides. It's a slightly older slide that compared the IAP guidelines of 2017 with the European guidelines. It emphasized much of the similar high-risk stigmata or absolute indications for surgery. As you mentioned, they are essentially very similar. There is some difference. The IAP group are more inclined to resect MCNs. The Europeans tend to look for sort of high, again, absolute indications. And again, the difference between the two guidelines largely represented, although the worrisome features were much the same, the way to proceed is somewhat different. So in the IAP, if you have a worrisome feature, they emphasize the utility of EUS in helping to decide whether you go to surgery or surveillance. The European guidelines emphasize whether you have comorbidities or not in terms of whether you go to surgery or surveillance. And yeah, in terms of the risk factors that we spoke about just now. But having said that, as we've said, the IAP guidelines all about those worrisome features. But of course, the European guidelines say, well, you should do an EUS if it's going to change your clinical management or if there are clinical or radiological features of concern, which, if you think about it, is probably going to be almost all patients. So in actual fact, what the guidelines are saying is that you should have a very low risk, a low index of suspicion, or rather a low index for using EUS to help guide your management. So just to add a little bit of evidence to that, so in terms of literature that has looked at the optimal imaging for these lesions, so first of all, comparing CT scans and MRI or MRCPs. So I think the first thing is that there's really good evidence now that MRI and MRCP is much better in terms of accurate sizing, detecting ductal communication, estimating main duct involvement, and identifying side branch cysts. But it's really looking at the content and the nature of these cystic lesions. We recently had a patient that had a CT scan. To all intents and purposes, it looked completely like a cystic lesion, and the patient went for EUS, and in fact, the entire thing was solid, and in fact, it was the consequence of TB. So perhaps to put that in sort of practical context, This is an example of a patient who, a 56-year-old man who presented with an incidentally discovered lesion. You can appreciate on the CT scan, it basically shows the lesion over there, and maybe there's the hint of a septation there, but it's quite difficult to appreciate. We look at the MRI, there's a clear septation in the cyst. And the relevance of that is it makes a tumor lesion far more likely. This could easily still have been an inflammatory and a residual inflammatory cyst from a previous attack of pancreatitis. This septation is very much likely to not be the case and is rather a cystic tumor. And then moving on to other views on the same MRI, MRCP, we can see the cystic lesion, we can appreciate that septation, and we can also appreciate how this seems to communicate with the pancreatic duct or the side branch of a pancreatic duct on this MRI. And this virtually makes the diagnosis of a side branch IPMN, whereas the CT scan was not able to do that. Okay, so I think we can agree that MRI is the cross-sectioning imaging tool of choice in cystic tumors. Having said that now, what about endoscopic ultrasound? So now there's good evidence that endoscopic ultrasound is even better than MRI. And it is the most sensitive diagnostic modality and is better able to correctly classify cystic neoplasms. It has a better nodule and septation detection rate, and that is really key in evaluating these tumors. It's also best in visualizing the pancreatic duct. So again, to just return to our same patient, that was the MRI. This is what the EUS looked like. Clear evidence of a septation, in fact, multiple septations, which would, again, raise the chance that this could be a serous cyst adenoma or an IPMN. But we're still concerned about IPMN. But when we look more carefully on the endoscopic ultrasound, in fact, there's a papillary projection from a mural nodule over here. And in fact, this measured more than 5 millimeters. So in actual fact, this would potentially qualify this patient for a section. So EUS really is probably your best modality in terms of demonstrating the characteristics of a cystic lesion. Now, that's not the end of the story, because EUS offers you other advantages as well. So first of all, you can aspirate some fluid, and you can send that fluid off for cytology. The results on that are not great. Okay, so the sensitivity of fluid cytology is probably only around 30%. However, we'll talk a little bit. The other things that you can do is once you've aspirated your cyst to dryness, you can pass your needle through the wall of the cyst and what remains of the cyst and obtain tissue that way. That gives you a mural biopsy. While in addition, there are also specifically designed forceps that you can pass through your needle and onto the distant wall and actually take biopsies, focused biopsies, much the same way that you take an endoscopic biopsy when you biopsy the edge of an ulcer, for example. And that can actually give you tissue. The fragments are quite small and you need a pathologist that's quite dedicated, but nevertheless, it is something that you can do. Now, the sensitivity of fine needle biopsy cytology of the wall is much better. That's in the region of 70 to 90%. But the other useful thing that that EUS can do in terms of when we address these cysts invasively is we can get some fluid and we can test that fluid for CEA, glucose, and lipase. Amylase or lipase will tell us whether or not there's ductal communication, would perhaps suggest to us whether something is IPMN or MCN, and even if it's IPMN as opposed to a serous cyst adenoma. Glucose levels is something that's been developed relatively recently, but low glucose levels are associated with mucinous lesions and mucinous tumors. And lastly, CEA, in particular, a value of 192 nanograms per mil is associated with mucinous lesions. So in other words, if the CEA is high, above this value, it suggests a mucinous neoplasm, either an MCN or an IPMN. It doesn't differentiate between the two. And important to remember is it doesn't differentiate between benign and malignant disease. So just because you've got a raised CEA, that indicates that you have a mucinous lesion, but it doesn't necessarily indicate that you have carcinoma. Okay, so I think that's really where I'm going to end my story. Just to conclude, pancreatic cystic lesions and in particular incidental ones, they remain a diverse and a potentially complex group of conditions, and they have variable implications. The challenge remains balancing malignant risk against unnecessary surgery with its attendant risks. MRI and MRCP is without question the preferred cross-sectional imaging modality, but EUS may hold some additional advantages in terms of delineating and describing the cyst, and certainly in terms of additional investigations. So there's not perhaps consensus on its precise role, but certainly it is extremely valuable and offers additional diagnostic clarity and information to aid decision-making. Sorry, I'm just trying to advance here. Right. Guidelines are in agreement regarding high-risk features that are clear indications for surgery. There's still a little bit of discrepancy in terms of evaluation and management of relative risk or worrisome lesions. But certainly, I think there is a move away from pure size being how concerning size should be based on its own, and certainly we should be looking at cysts in a sort of holistic kind of way, taking multiple factors into consideration. Really, the decision making is individualized. It's dependent on your degree of suspicion for a sinister lesion, and here EUS is really, I think this is where it comes into its own. And of course, we have to take into account patients' general health and comorbidities. As I've shown you, not infrequently, patients are reassured and perhaps inappropriately so, or at least not subjected to close surveillance. And I think really what it does emphasize is that these lesions can be complex and they can be dangerous. And it really, I think involving colleagues in a multidisciplinary team environment is only to the benefit of patients. And really, I think these lesions should be evaluated in that type of context. Okay. That is the end of my story. I think we're just on 1 hour. I hope I haven't overstepped my mark, but happy to take any questions. I see a message from John. It looks, I think he's needed to step out. He was going to ask Bilal to conclude. Again, I'm not sure if you want. I don't see any questions in the chat room. I'm not sure if anyone wants to raise their hand, or otherwise just unmute and ask a question.
So Sean, maybe if I can just start with a question. I mean, EUS capabilities are still not all that widespread, especially in the Southern African region. Looking at your other modalities in terms of better follow-up for these patients, is this just a matter of spreading the skill wider? Because I think you and in your center and us up here, we're quite lucky. You
African context, I think EUS is pretty freely and widely available. And so I think within South Africa, if it's not available in your center, there should be a center not too far away that patients can get to, even within the state sector. Moving a little bit further afield, there are certainly it's available in Namibia. And we have colleagues who are trying to develop it within Zimbabwe. and Botswana, but certainly there's still some room to work there. I think moving further afield, certainly in Kenya, but I think within other aspects of Southern Africa, there may be challenges. And I think it depends to a large degree on what is available to you. So, I mean, I would think that CT scans are probably fairly widely available. We should never forget transabdominal ultrasound. Now, it may not be applicable in every patient, but certainly it's worth trying a transabdominal ultrasound. And if you can see the lesion, particularly if it's in the body or the tail, that may be something that one can utilize. But again, quite often it's about, again, it's about looking at the patient holistically. What is this patient's risk profile like? What does the cyst look like? Understanding the limitations of CT scan. And I really want to emphasize that. CT is great at picking up that there's something there, but it's really not great at delineating what is there. And it can offer you a false sense of security. And so I think if you're using CT scan alone, then your index of suspicion for further intervention needs to be quite low. And if there's any evidence of progression or any sort of clinical concern, especially development of an enlarged duct, evidence of ductal obstruction, either biliary or pancreatic, lymphadenopathy, and clinical things like recurrent pancreatitis or a serum CA19-9 that is elevated. I think those are factors that you really need to take into account that would probably push you towards being more interventional.
Yeah. No, fantastic. Thanks. I think the whole concept of EUS does kind of lend itself to the iEcho platform and might be something for us to consider in future. Yamkela,
yeah, if I can speak to that, Bilal, yeah, I mean, I'm more than happy to try and assist with that process. We have a recently established EUS working group. It's something that's been in the pipeline for a while, but Colin Knoll from Bloom is driving that process now, and we and myself and John have been very much involved in that. I think EUS is evolving as an extremely valuable tool in gastroenterology.
100%.
And it's almost indispensable in our HPB practice now. So if one's looking to put together some talks or some sessions on EUS, as a group, we would be more than happy to support that and
100%.
offer something.
I mean, if I can be bold enough to include Neo and Didi Mokoko that are doing fantastic work with EUS and especially helping us in the hepatology sphere with coil and gastric varices and doing all sorts of embolizing shunts and that sort of thing. So it really is something which is exciting. Sean, just to draw your attention to Dr. Desimela's question, how to differentiate de novo PDAC versus concomitant PDAC and IPMN.
Sorry, how to differentiate de novo?
Open up your chat there. Yeah, I've just read it.
Okay. Yeah, okay. That's certainly a challenging question. It depends to some degree on what preceding information you have. Almost always the patients who present with a PDAC from an IP. So I think the first thing to say is it's probably the relevance of that probably has mostly to do with what you're going to do afterwards. Okay. In terms of assessing that individual patient and what treatment is appropriate for that individual patient, it doesn't really matter whether you're talking about a de novo PDAC or a PDAC that's arisen from an IPMN. You're still going to go down the same route of assessing resectability, making the diagnosis, staging the patient appropriately, putting them through an MDT and deciding, are you going down a neoadjuvant route or upfront surgery route or a palliative route? So the specific things of managing that particular lesion is the same between the two. But where the relevance comes in is probably if you know that you have a tumor that has arisen in an IPMN, at your surgery, you're going to do frozen section of your pancreatic duct to see whether there is dysplastic epithelium at the time of your surgery. If there is high-grade dysplasia in the pancreas that is remaining behind, clearly you need to extend your resection and take that tissue. And there may be a role for doing an on-table pancreatoscopy in that instance as well. That is something that I've done in the past, and it has changed the patient's management. Whereas if you're doing a stock standard PDAC, those factors don't necessarily come into play. It relates to that field effect that I was talking about that IPMN has. The other issue is around follow-up. In a patient with IPMN, essentially you would subject those patients to lifelong follow-up. And it's quite interesting. I spent some time in Fukuoka where the original guidelines were written. And in fact, the Japanese, what they will do is they'll actually, in patients that they are surveilling, they will do annual directed sampling of fluid from the pancreatic duct. So in other words, they'll do an ERP, pass a catheter up the pancreatic duct and aspirate fluid under the influence of secretin and send that for cytology and sometimes genomics and tumor markers. So the point is that it does affect how you would surveil your patient. It does affect how you would do your surgery. Most of the time, making the differentiation, a PDAC will present as a purely solid lesion, a PDAC that's arisen from IPMN. There will be some evidence of IPMN disease, either a cystic component to it or other cysts or changes in the main duct. Although, of course, just with a stock standard PDAC, you may get some ductal obstruction and dilatation. But often what you have is evidence that there was a cyst before. As in the patient that I described earlier on, who had a 4-centimeter cyst, was assumed to be a simple cyst, although there really isn't such a thing, and left alone. And that patient, when they presented with a tumor, was clearly having arisen from a previous cystic lesion. So I hope I've answered the question. I'm happy, Yamkela, if I haven't, you're welcome to raise your hand or drop a comment in the chat box again. I think John is back and he has his hand raised.
Thanks so much. Yeah, I'd just like to echo your words on that. And I think the only way to differentiate that is in the setting of an IPMN. If you do develop a PDAC, especially a mixed type IPMN, or main duct type IPMN, I think it's going to be in the multi-omics of the tumor itself, looking at GNAS and the KRAS sort of mutations, which can really differentiate it. But ultimately, I think there is some evidence suggesting that, it may be slightly better once the outcomes and overall survivals might be slightly better in these cystic neoplasms, but that really hasn't been our experience. Once they become malignant and once they are PDACs, they really behave as this stock standard garden variety type PDAC, and it obviously hones down to the multi-omics. So I think if you had two separate lesions, if that's what you're asking, then it would only be able to be differentiated on multi-omics at this point in time, I would imagine. So I would like to echo that. Thank you.
Yeah. So John, I agree with you. I think there is debate around whether there's a difference in sort of behavior, biological behavior between the two. And I'm aware of literature sort of in both directions. There are people who have said that, that a IPMN tumor is perhaps a bit better. But I must say I'm aware of evidence pointing in the other direction as well. So I don't think that we have enough information to say one is better or worse than the other.
Okay. John, seeing as you're on, would you like to close then? We've had a good 15 minutes of further discussion, which is great.
But I'm happy for you to go ahead.
Okay.
Thank you.
So Sean, John, thank you so much on behalf of the Gastro Foundation and the Gastro Echo team. I, of course, want to thank the presenter. Sean, you did a great job. It's one of those topics where you, as a non-HPB surgeon, you do need regular updates and thought processes in terms of how to go through it. So really appreciate your efforts, Sean, in putting it together for us and explaining it so clearly. I want to thank the GastroEcho team, both locally as well as the University of New Mexico and Echo India team. Thank you for putting it all together. And then I'm not sure what next week's session is going to be. John, do you have that information?
It's HCC.
It's HCC.
Oh, there we are. Okay, there's Cheryl. Thank you, thank you, Cheryl. So next week's going to be HCC, 4:30 as usual. See everyone there. Thank you very much, everyone, and have a good night.
Thank you very much, and thank you for the invitation.
Thanks, John.